A 19-year-old Caucasian woman was referred to our clinic for evaluation of amenorrhea. This was an unusually late presentation for the investigation of primary amenorrhea. She had been investigated for thyroid dysfunction as the presumed cause of her amenorrhea at the age of 14 years. Her serum thyroid hormone levels were normal at that time, with thyroid-stimulating hormone, TSH, level of 1.4 milli-international units per liter, the normal range being between 0.4 to 4.2 milli-international units per liter, and free thyroxine, FT4, level of 14.6 picomoles per liter, the normal range being between 12 and 2.4 picomoles per liter. No further investigation was undertaken, and there was no family history of thyroid cancer. We obtained informed consent from our patient for diagnostic procedures and treatment, as well as consent for inclusion of her data in an anonymized scientific report. A physical examination showed that development of sexual characteristics was not entirely normal, although the development of secondary sexual characteristics was normal. Investigations included abdominal and pelvic ultrasonography and magnetic resonance imaging. Type 1 MRKH syndrome was suspected because of the total absence of the uterus and fallopian tubes. She had had a vaginal remnant measuring 1.8 centimeters in length. Both ovaries were normal, and no other structural abnormalities were found. Examination of the thyroid gland showed enlargement with a mobile 2.3 centimeter diameter solid nodule in the left lobe. There were multiple mobile left lateral cervical lymph nodes with a maximum diameter of 1 centimeter. Thyroid function testing showed normal serum levels of TSH, 1.8 milli-international units per liter, and anti-thyroid peroxidase antibody, less than 34 milli-international units per liter. Thyroid ultrasonography showed a hypoechoic left thyroid nodule with increased central vascularity. According to the current guidelines for evaluation of thyroid nodules, fine needle aspiration biopsy, FNAB, was indicated. The FNAB showed high cellularity in the nodule, with a cytological examination showed follicular lesions that were classified as Thy3 according to the latest classification system. Technetium 99M pertecnenate thyroid scintigraphy, 185 megabecquerel, showed a nodule in the left lobe with no metabolic activity, a cold nodule. The combination of clinical features, cytological examination findings, and imaging findings led to a diagnosis of nodular goiter highly suspicious for malignancy. She was referred to our surgery department for total thyroidectomy with a selective lymph node dissection. Pathological examination of the surgical specimen confirmed a 2.1 centimeter diameter papillary thyroid carcinoma in the left lobe with invasion in the thyroid capsule. 3 of 16 removed lymph nodes were positive for cancer. The cancer was classified as stage 1, according to the American Joint Committee on Cancer, Union International Contra le Cancer Staging System, 7th edition. Prognosis: thyroid carcinoma and Meyer-Rokitansky-Kuster-Hauser syndrome.